is my great honor to introduce Dr. Amy Rubinowitz. She did her MD at New York Medical College. She did her chief residency and fellowship in thoracic imaging at NYU, where she then went on to become an assistant professor for 5 years. And then we were lucky enough to recruit her here in 2005, which was just the year before I came. And we've kind of grown up through the system together, and it's really been a privilege to be able to work with her for all of that time. She's actually had quite a prolific career and was promoted to professor of radiology and biomedical imaging in 2022. She's been heavily involved in the leadership of the thoracic imaging section for much of her time here. And she's been a central radiologist in the important programs to us as a section. So our ILD conference, our thoracic oncology conference, and tumor board, it's really incredible to have her involved in those kinds of things. And what really sets her apart is her love for and her excellence in teaching. So she has won multiple teaching awards throughout her time in training and here at Yale. I have never seen so many lectures on educational topics on one CV. I counted. She has done 194 lectures on radiology topics because she's just an amazing educator. And so that's really what we love about working with her, is that she has an amazing eye. She has amazing pattern recognition, and she has the ability to share what she's seeing with all of us so that we can learn from her every day. So I'm really excited to have her talk with us today and to learn from her. Welcome.
Thanks so much, Danielle. That was such a nice introduction. So I would just want to first start out and say like how fortunate I am to be able to work with, collaborate with, and learn from the pulmonologists here at Yale. You are all such an incredible group of talented physicians, and that I've been able to learn from you and work with you for so many years. I'm really grateful and fortunate. And this is, truly, it's, well known that you guys are not just one of the best departments in the country, but also in the world. So I'm really lucky to be able to know you guys as friends and colleagues. And sorry, let me just change this. Uh-oh, it won't let me move. I'm stuck. Little technical difficulty. I know. Sorry. I'll be starting my talk in just a moment.
I think because you changed.
Oh. I mean, you can put it back the other way if you want. We're just trying to figure out how to get the slides to advance.
Do you know how to? I know that's familiar. The escape's not working. That's weird.
You want me to? Yeah, it was working just a minute ago. What about Control Alt Delete?
Still not pulling that down though.
Yeah, the computer's frozen. Oh.
No.
Oh. Wait, maybe there. All right. I mean, I think it'll It's advancing when I click, I guess, the mouse. So let me see, we'll go back. Yeah, no, those aren't working. But anyway, all right, I'll, if I right click the mouse, it will, yeah, hopefully it'll work. Let's see if I can do it that way. So anyway, I also want to thank Richard Mathey for inviting me today to give this talk. And whether he knows it or not, he has really been a mentor to me since I started here many moons ago. He's really helped me come a long way academically, and he is not only an outstanding clinician, he's also an all-around wonderful person. Next. That's weird. Anyway, okay, we're gonna muddle through this. I also have to give a shout out to the interstitial lung disease group. This was the original, the OG ILD group when I first got here. Danielle, Murdu, Jonathan, and Erica. And this group was really like responsible for sparking my interest in interstitial lung disease and helping me to grow my expertise through all these years. And, you know, I love working with them. I work the closest with them out of most of the department, and I'm very thankful to be a part of them. Now, some of them have gone on to bigger positions. But there are newer superstars in the ILD group, JP, Yuli, Alex, and Genta, and they truly are a group of brilliant clinicians, and so incredibly dedicated dealing with a lot of very complicated patients. So now onward, sorry, this is. I mean, I'm basically just right clicking and doing next, I guess. So it'll work. So anyway, so yeah, excuse me, it's going to be a little slower as I advance through the slides, but I'll try to speak a little faster. So basically the objectives of my talk are to, I'm going to be summarizing the variety of manifestations in the thorax that the connective tissue disorders can display. I'm going to highlight common CT patterns of lung injury in connective tissue disorder patients. And I'm also going to review complications of treatment of these disorders, as well as other entities that these patients are at increased risk for. So the connective tissue disorders are a group of autoimmune diseases whose common denominator is damage to components of connective tissue disease, of the connective tissues at various sites throughout the body. These overall are more common in women than men and typically present in young to middle-aged adults, so usually around the 3rd to 5th decade of life. This is the main group of connective tissue disorders that I'm going to be referring to today, and I have them listed in order of prevalence, from most common being rheumatoid arthritis to least common being Sjogren's syndrome. Okay. Thoracic involvement by the connective tissue disorders, it's important to be aware, it's not uncommon that when I'm interpreting a chest CT, sometimes I may find interstitial lung disease that's totally in a patient that's asymptomatic and completely unsuspected, especially if it's mild interstitial lung disease. And it's actually, what's interesting is oftentimes the lung manifestations the lung findings may be the first manifestation that the patient has or is going to develop a connective tissue disorder, either now or in the future. And sometimes the lung findings actually may precede the patients having clinical symptoms or positive serologies of a connective tissue disorder, sometimes by months to even years. In the literature, thoracic involvement by the connective tissue disorders, there's a humongous range in the literature when you look at the papers. And I think a big part of this has to do with a lot of the literature is before the widespread use of CT. And as we all know, CT is much more sensitive and specific than chest X-ray. So a lot of the older literature was based on X-ray, and patients who have interstitial lung disease, especially if it's mild, X-ray is just not going to be sensitive enough to detect it. So the connective tissue disorders can affect the thorax at many different levels, and oftentimes involve more than one compartment of the chest. And that's what can be helpful when looking at a case of interstitial lung disease. If I see more than one of these compartments involved, sometimes I may suggest, if it's not already known, that the patient may have an underlying connective tissue disorder. And besides infection, interstitial lung disease and pulmonary hypertension are actually the biggest causes of morbidity and mortality in these patients, as far as thoracic involvement. So first, I'm going to start out by talking about parenchymal involvement, more specifically interstitial lung disease. Just a small aside, basically my talk, this is going to be mainly a general overview of involvement of the thorax by connective tissue disorders. I could actually go through each section in much more detail, but we'd probably be here well into the night, which I don't think any of us really want. So this is more general overview, and if people have more specific questions afterwards, I'm more than happy to answer them. So parenchymal involvement by the connective tissue disorders, or more specifically interstitial lung disease. So in all takers, all the different connective tissue disorders put together, approximately a third will have some sort of interstitial lung disease. Scleroderma or systemic sclerosis has the highest incidence out of all the connective tissue disorders of having interstitial lung disease. And actually, autopsy studies of patients with scleroderma, up to 80% of those patients will have abnormal lungs at autopsy. It's important to remember, out of the interstitial lung disease, overall, NSIP, nonspecific interstitial pneumonia, is the most common pattern that we'll see in these patients. And when we see NSIP at imaging, it's this from an underlying connective tissue disorder. It's the same exact pattern that we see in patients who have idiopathic NSIP, which is actually not very common. However, UIP more commonly is idiopathic, and then it's termed IPF. And again, the pattern that we see at imaging, if we don't know anything about the patient, we cannot distinguish. It's the same exact pattern that we'll see with their idiopathic counterparts. In general, interstitial lung disease in patients who have connective tissue disorder, in general, they have a better prognosis than their idiopathic counterparts. And part of that may be, again, that NSIP is the most common pattern, and NSIP usually has a better prognosis than UIP, or usual interstitial pneumonia. And when we see patients with interstitial lung disease having involvement of other compartments in the chest, that's much more likely to be seen in patients with connective tissue disorders than idiopathic interstitial pneumonias. So I'm going to start out by talking with parenchymal involvement or interstitial lung disease with the fibrosing interstitial lung diseases briefly. So this is a patient with rheumatoid arthritis, and this patient has a classic UIP pattern. On the axial slice, we see fibrosis that is peripheral predominant with honeycombing, and on the coronal reformatted image, you see a nice apical basal gradient of fibrosis, with most of the fibrosis involving the lower lobes. And again, for us to call a UIP or a definite UIP pattern, we need to see these honeycomb cysts, these small subpleural cysts that usually stack upon themselves, and they start in the immediate subpleural lung. UIP pattern in patients with connective tissue disorders, or the connective tissue disorder that most commonly will have a UIP pattern, will end up being rheumatoid arthritis. That's the most common pattern that we'll see with them. Now, this pattern of interstitial lung disease, this is a nice example of nonspecific interstitial pneumonia. And this patient has lower lobe predominant interstitial disease with ground glass opacities and traction bronchiectasis. You can also see, we don't always see this with NSIP, but if you do see it, it can be a helpful sign. But we see immediate subpleural sparing, or the immediate subpleural lung is not involved, whereas with usual interstitial pneumonia, UIP always starts in the immediate subpleural lung and works its way in. And this was a patient with scleroderma. Patients with an NSIP pattern who have connective tissue disorders, most commonly we'll see that in patients who have scleroderma, as well as antisynthetase syndrome, which is one of the idiopathic myopathies. So before, a little while ago, I mentioned that when we see a pattern of interstitial lung disease at imaging, as radiologists, we can't distinguish it from connective tissue disorder associated interstitial lung disease or idiopathic interstitial lung disease. But in the past several years, there are some signs in the radiology literature that when we see these signs at imaging, and I definitely look for these signs or use these signs to help me distinguish, is this a patient who has or will have underlying connective tissue disorder, or is this idiopathic interstitial lung disease? So just to go through the signs, the exuberant honeycombing sign is basically just like what it sounds like. You see lots of honeycomb cysts or exuberant like honeycomb cysts involving greater than 70% of the fibrotic portion of lung. So when I see a case of UIP, usual interstitial pneumonia pattern, and there is so much honeycombing taking up a large majority of the lung, then I'm thinking that the patient has an underlying connective tissue disorder, most commonly rheumatoid arthritis. Another sign that you can see more commonly with UIP than NSIP is the anterior upper lobe sign, and that's also just like what it sounds like. On the axial image, basically, you'll see a concentration of fibrosis in the anterior aspect of the upper lobes. And here we see a tiny bit of subpleural honeycombing, but also traction bronchiectasis in a patient with rheumatoid arthritis. The straight edge sign, this sign is a sign that we see or look for on the coronal reformatted images. And it's also just like what it sounds like. So basically here we see a sharp demarcation between normal and abnormal lungs, such that you can draw a straight line right across, demarcating the abnormal from the normal lung. And this sign not only helps differentiate connective tissue disorder associated ILD from their idiopathic counterparts, but this sign we'll actually see more commonly in NSIP than with UIP. And here, this patient had scleroderma with NSIP with lower lobe, kind of diffuse peribronchovascular, predominant ground glass opacity, and traction bronchiectasis. And then the last sign, when we see this sign, that also helps us suggest that we're dealing with interstitial lung disease from a connective tissue disorder rather than idiopathic counterpart, is the four corner sign. And this sign, most commonly, we'll see in patients who have scleroderma. We can see it basically in patients who have inflammatory interstitial lung disease or fibrotic interstitial lung disease. And again, most commonly in the setting of scleroderma. So basically on an axial image, you will basically see either inflammation and or a fibrosis involving the four corners of the lung on that slice. The anterior lateral aspect of the upper lobes and the posterior aspect of the superior segment of the lower lobes, making the four corners. Other findings that we could see with parenchymal involvement in patients with interstitial lung disease include organizing pneumonia. Organizing pneumonia is very commonly seen in patients with connective tissue disorders. This was a patient with polymyositis who had peripheral consolidations and ground glass opacities in a nice distribution that suggests organizing pneumonia. Here's a patient with rheumatoid arthritis on the right, with peribronchovascular ground glass opacity in the right lower lobe, a little bit in the left lower lobe. And you can actually see this ground glass opacity is demarcated by an area of increased density, sometimes an area of consolidation surrounding ground glass opacity. And that's referred to as the reverse halo or the atoll sign. And this is very similar to this picture that I got off the internet. And in case any of you are wondering what an atoll is, it's a coral reef encircling a lagoon. These are usually found in the South Pacific. And that's exactly what this imaging sign looks like. And this sign initially was described with organizing pneumonia, but we can also see this with other entities as well. If I see a patient who has multiple lung cysts or cystic lung disease, especially if the cysts happen to look like they have a little vessel running along the wall, what we call perivascular cysts, and this patient has multiple cysts bilaterally in their lungs. They also have a little bit of ground glass opacity here in their lingula. This was a patient with LIP or lymphocytic interstitial pneumonia, which is rare. But when I see a case of LIP, most commonly we're going to see that in the setting of Sjogren's syndrome. Some of the other connective tissue disorders can end up getting LIP as well, but mostly or much more commonly we'll see it with Sjogren's syndrome. You can also see LIP in the setting of immunocompromised patients or patients with AIDS, HIV, but that looks different than the LIP that we see with connective tissue disorders. Their LIP looks just like they have pneumocystis pneumonia. They have diffuse ground glass and maybe some small cysts. And usually that diagnosis ends up getting made at pathology rather than at imaging. Here's another finding that we can see. This is one of the most dreaded findings that we see in patients with interstitial lung disease as well as connective tissue disorders. Diffuse ground glass opacity representing diffuse alveolar damage. Diffuse alveolar damage is actually what we see at histology in patients who have ARDS or what we call an acute exacerbation of interstitial lung disease. And the patients with connective tissue disorders who are at the most risk of developing diffuse alveolar damage include dermatomyositis as well as lupus, but technically any of them can develop diffuse alveolar damage. And also, just another thing to point out, as a radiologist, when we see a case of diffuse ground glass opacity just like this, the majority of times we can't reliably distinguish from imaging at this point. We don't have a microscope yet on our CAT scanners, but maybe in the future, but we can't reliably distinguish diffuse alveolar damage or an acute exacerbation from diffuse infection, from pulmonary hemorrhage, from acute inflammation, maybe in the setting of drug toxicity, or even from pulmonary edema. And in those cases, that's where our brilliant pulmonary colleagues come in, look at what's going on clinically with the patients, and sometimes they end up needing a bronchoscopy to differentiate. So this is basically, I went through the different parenchymal patterns that we can see in patients with connective tissue disorders. And next to each pattern, I list the connective tissue disorders that most commonly will have that pattern of disease. But that being said, any of the connective tissue disorders can manifest with any of these patterns as well. However, some patterns are more common in certain connective tissue disorders than in others. And mixed connective tissue disorder, I don't have that listed here, but because that's kind of a mishmash of different connective tissue disorders or more than one connective tissue disorder, mixed connective tissue disorder, those patients can manifest any of these patterns as well. Okay, now I'm going to move on to involvement of the pleura and pericardium in these patients with connective tissue disorders. So involvement of the pleura and pericardium, we can see it as pleural and pericardial effusions, bilateral pleural effusions. Here's a moderate to large pericardial effusion in a patient with rheumatoid arthritis, another pericardial effusion in a patient with lupus. And actually, in patients who have rheumatoid arthritis and lupus, the serositis that they get is actually the most common, or one of the most common manifestations that we'll see at chest imaging, even more common than interstitial lung disease. So, and when these patients get pleural effusions, typically if you sampled them, they would be exudative unless the patient, if it's a patient with lupus, has end-stage renal disease and their volume overloaded. In those cases, their effusions may be transitive from volume overload, but usually their effusions are exudative, whether you sample the pericardial or pleural effusion. And also their pleural effusions tend to be small and symmetrical, or small to moderate in size and symmetrical. It's very uncommon to see a pleural effusion in a patient with connective tissue disorder that's from their underlying connective tissue disorder that's unilateral and large. Then we're going to think about something else besides it being from their underlying connective tissue disorder. Airway involvement in patients with connective tissue disorders. So in addition to interstitial lung disease causing traction bronchiectasis, you can also get bronchiectasis, airways bronchiectasis. And just to distinguish between the two, traction bronchiectasis, it's not the airways that are abnormal. The lung around the airways is abnormal and fibrotic, and it pulls apart and dilates and distorts the airway walls and makes them bronchiectatic. Whereas true bronchiectasis, the abnormality is with the bronchi. So rheumatoid arthritis, commonly we can see bronchiectasis in the setting of rheumatoid arthritis. We can also see bronchiectasis, specifically lower lobe bronchiectasis, in patients who have scleroderma with esophageal dysmotility if they have repeated aspirations. One of the most common causes of bronchiectasis will be recurrent repeated infections or patients that aspirate. We can also see obstructive small airways disease in patients with connective tissue disorders. And this is a patient with rheumatoid arthritis. Most commonly, when we see bronchiolitis obliterans, or out of all the connective tissue disorders, RA probably is the most common one that will manifest with bronchiolitis obliterans. And what we see in these cases, this is the same patient. On the left is them at inspiration, and on the right is them exhaling. And if you see on the inspiratory slice, the lungs are not homogeneously gray, they're heterogeneous. We have what we call mosaic lung attenuation or mosaic lung perfusion. We have lucent areas and then areas of grayer lung. Now, in these cases, it's the lucent areas that are abnormal, and we can see with our expiratory image, the lucent areas stay lucent and they stay inflated, whereas when somebody exhales, the alveoli should collapse down and the lung should get grayer. So the grayer lung here is actually the normal lung, and this patient has a lot of air trapping. Not everybody with air trapping has bronchiolitis obliterans. We can see severe air trapping in patients with asthma, COPD, patients that smoke. But if I see a patient that has air trapping that's moderate or severe, sometimes I'll suggest this diagnosis in addition to other causes of obstructive small airways disease. And usually these patients are pretty compromised clinically. They have progressive worsening shortness of breath, and their pulmonary function test will be obstructed, and they won't respond to bronchodilators. Follicular bronchiolitis is a very uncommon manifestation that we can also see with connective tissue disorders. Usually we'll see this in the setting of Sjogren's, and what this represents, these little tiny clustered centrilobular nodules, these at pathology end up being lymphoid aggregates in and around the walls of the small airways. With follicular bronchiolitis, sometimes you can also see small cysts. But when I see a case that looks like this, much more commonly than follicular bronchiolitis, instead of lymphoid aggregates filling these small airways, causing these little clustered, almost tree and bud nodules, much more commonly when we see this pattern, it's going to be from small airway infection, mucus impacted small airways. I'm going to move on to vascular involvement in patients with connective tissue disorders. So pulmonary hypertension, again, is one of the biggest causes of morbidity and mortality in these patients. And we can see pulmonary hypertension in patients who have interstitial lung disease. Any patient with chronic lung disease is at increased risk for developing pulmonary hypertension, as well as we can also see in the setting of scleroderma and lupus. Even if their lungs are normal and they don't have underlying fibrotic interstitial lung disease, just from their underlying vasculitis, they can have pulmonary hypertension. And at imaging, what we look for is if we measure across the diameter of the pulmonary artery, if we measure across this way, if it's 3 centimeters or greater, that usually is too big, and that can suggest that they have pulmonary hypertension. That being said, there are patients who have pulmonary hypertension, and sometimes their pulmonary arteries are normal size. So the gold standard for this diagnosis is going to be right heart catheterization. Pulmonary emboli. This patient here has a saddle embolus. There's low density filling defect or clot extending across the main pulmonary artery from the left to the right main pulmonary artery. So patients with lupus are definitely at increased risk for developing pulmonary emboli, especially if they have antiphospholipid antibody syndrome. And we can also see pulmonary emboli in the setting of fibrotic lung disease. Patients, whether they have connective tissue disorder or fibrotic interstitial lung disease from some other cause, they are actually at increased risk for developing pulmonary emboli like this patient here. And then musculoskeletal involvement. So the connective tissue disorders can also involve the bones and soft tissues. And when I'm reading a chest CT, even though I like to look at the lungs the most, the radiologists are looking at everything on the image. And that includes all of these other compartments that I mentioned, including bones, soft tissues, the lower neck, and the upper abdomen. So there is something known as shrinking lung syndrome. Some of you, if they're fellows or medical residents, sometimes this comes up on board exams, but on the board exams, they like to ask things that are rare clinically, but they're more commonly seen on board exams. So shrinking lung syndrome, just to touch on that, and I had to look really hard to find a case of this. That's typically seen in patients with lupus, and it's usually a manifestation of diaphragmatic muscle weakness and or phrenic neuropathy. And what happens is these patients get progressively elevated diaphragms with resultant decreased lung volume. So it looks like their lungs are shrinking. And this was the same patient who had lupus, and these two x-rays are several years apart. So this patient here has lower lobe predominant or consolidation in both of their lower lobes, and this was from aspiration. Patients with the inflammatory myopathies, dermatomyositis, polymyositis, antisynthetase syndrome, they can have involvement of their pharyngeal muscles. Their muscles can become weak, which predisposes them to aspiration, as well as patients with scleroderma. They tend to aspirate, not from muscle weakness, but in the setting of esophageal dysmotility. And here's a patient with calcinosis. So this is also not a very common manifestation, but when we do see this, this makes for nice images for talks or articles or textbooks. So this was a patient who had scleroderma. Here's their x-ray, and they actually had lower lobe interstitial lung disease. But what we see are these amorphous calcifications. Here's on their x-ray, here's on their CAT scan. Around, usually the calcinosis tends to be around the glenohumeral joint. Sometimes they'll be around the sternoclavicular joint as well. And you can also see this patient has a dilated esophagus. You can also see soft tissue calcification uncommonly in patients who have dermatomyositis. And patients with lupus, if they have end-stage renal disease, they can get something called tumoral calcinosis, where they can get soft tissue calcifications as well. This is a nice boards type case as well. If you see a patient who has interstitial lung disease, like this patient with rheumatoid arthritis, we see coarse interstitial markings on their x-ray. They have small lung volumes because they can't take a deep breath. They have restrictive lung disease and either severe erosive arthritis or a joint replacement because they had severe erosive arthritis. think about rheumatoid arthritis. So we can look for other clues if we see interstitial lung disease and try to come up with a diagnosis here. Distal clavicle resorption is also another clue sometimes that the patient has a connective tissue disorder. This is what a normal distal clavicle looks like. It should be nice and squared off. This clavicle here looks like we call it penciling of the distal clavicle, almost like you put in a pencil sharpener. So they get erosive changes or resorption of the distal clavicle. And when we see this, usually rheumatoid arthritis, or patients with lupus if they have end-stage renal disease as a manifestation of secondary hyperparathyroidism. You can also see distal clavicle resorption. And then Rugger Jersey spine is another manifestation that we can see. Usually we'll see this in patients with lupus who have end-stage renal disease, secondary hyperparathyroidism. And this, these vertebral bodies are likened to these stripes on this rugby jersey. We have end plate areas of sclerosis with lucency in the middle of the vertebral body. So that's another manifestation, usually a manifestation of secondary hyperparathyroidism, but we can see that in the setting of patients with lupus. And then there are also other manifestations. I mentioned before, if the patient, if there's a patient with lupus and end-stage renal disease, they can get tumoral calcinosis, so calcification in the soft tissues. Rarely that can actually occur in the lungs as well. They can get brown tumors in their bones. And then also patients with lupus are at increased risk for developing avascular necrosis of their humeral head. So we may see sclerosis, deformity, and collapse of the humeral head. A lot of these patients are treated with steroids, and while steroids make them feel good and can help, sometimes help their lung inflammation, what's going on in their lungs, it also has some negative effects. So it can cause osteoporosis, and these patients can get spinal compression fractures, which we definitely see in them. And one of the adverse effects of prednisone that the patients like the least is fat deposition. So they end up getting fat deposition in their subcutaneous tissues, like this patient who was on long-term prednisone. And they can also get fat deposition in their mediastinum as well, what we call mediastinal lipomatosis. And there's more. So besides all of the other things that I just mentioned, going through each compartment of the chest, the different manifestations that we can see with connective tissue disorders, there are other findings that the connective tissue disorders can make on a chest CT. So I have these all highlighted in blue: pulmonary hemorrhage, pulmonary edema, drug toxicity, acute exacerbation, or I mentioned this earlier, diffuse alveolar damage, and infection. If these present as diffuse ground glass opacity at imaging, as a radiologist, majority of the times we cannot reliably distinguish among these different entities. And again, that's where clinical history, how the patient's doing clinically, lab values, and sometimes bronchoscopy come into play to differentiate these. So just to go through a little bit, finish up with some additional findings that we can see as well. So here's a patient with interstitial lung disease. It's lower lobe predominant with a lot of traction bronchiectasis and a dilated esophagus. So another nice board type case for anyone taking the boards in the near future. Fibrotic interstitial lung disease with a dilated esophagus, think scleroderma, or think mixed connective tissue disorder. Now, necrobiotic nodules always kind of makes me chuckle a little bit, because sometimes when I ask my residents to list some of the manifestations you can see in a patient who has a connective tissue disorder on a chest x-ray or chest CT, invariably this is the first thing that they mention. And this actually happens to be one of the least common manifestations, but they, for some reason, always remember necrobiotic nodules. And these are usually seen in older men with advanced rheumatoid arthritis. In the many years I've been practicing, I've seen maybe 3 path-proven cases of necrobiotic nodules. And what they look like at imaging, they look just like pulmonary metastases, multiple well-circumscribed, randomly distributed lung nodules. Usually they're solid, but they can be cavitary as well. Lymphadenopathy, so patients with connective tissue disorders can definitely have lymphadenopathy. It's usually not big, bulky lymph nodes. They usually have multiple small or mildly enlarged lymph nodes. It's not uncommon to see them in the axillary regions bilaterally, in the subpectoral regions, as well as in the mediastinum and hilum. That being said, if I see a patient who has lymphadenopathy that's increasing and becoming very big and bulky, then I'm going to start to worry that they're developing an underlying malignancy. And patients who are on chronic immunosuppressive agents are at increased risk for developing lymphoma, as well as patients with Sjogren's syndrome. They're also at increased risk for lymphoma. Thymic hyperplasia can also be seen in patients with connective tissue disorders. It's one of the causes of thymic hyperplasia. And basically in the anterior mediastinum, in a patient who's usually age 40 or over, the thymus should normally be totally fatty involuted. So if we're seeing what looks like a normal thymic tissue in a patient who's too old to have thymus, we think about thymic hyperplasia. And definitely we can see that in the setting of connective tissue disorders, among other entities. Drug toxicity. So what's interesting or unfortunate is many of the medications used to treat patients with connective tissue disorders are toxic, can be toxic to the lungs. And they can make the same patterns of interstitial lung disease as the connective tissue disorder itself. So it's very important if we're thinking about drug toxicity or you're thinking about drug toxicity in a patient to look at the timing of when they develop symptoms and imaging abnormalities from the time they were started on the medication. That's going to a lot of times be helpful distinguishing, am I seeing organizing pneumonia from drug toxicity, from their methotrexate, or is it organizing pneumonia from their underlying connective tissue disorder? And again, it makes the same exact patterns as the connective tissue disorders can make. Organizing pneumonia is usually the most common pattern that we'll see with drug toxicity. So we'll usually see airspace disease, ground glass opacities, and or consolidation. And you can see once the methotrexate stop, their lungs go back to normal. Acute exacerbation is something, again, usually a dreaded finding that we see. It's usually associated with a much worse prognosis in these patients. And like I mentioned earlier, at pathology, these patients will have what this represents most of the time is diffuse alveolar damage. Sometimes they'll see organizing pneumonia at pathology, and those patients usually will do a little bit better than if it's diffuse alveolar damage. So this was a patient who had mixed connective tissue disorder and mild peripheral fibrotic interstitial lung disease. And all of a sudden they became very short of breath. They deteriorated pretty quickly, got an imaging study. And this is with IV contrast because one of the other things that we were looking for in these patients is pulmonary embolism. But this patient developed all these new ground glass opacities. And the ones that end up doing okay or surviving the acute exacerbation, sometimes they'll end up, once the ground glass opacities clear, with worsening fibrosis in their lungs. And also, like I mentioned before, we can't reliably distinguish when we see bilateral ground glass opacities. If you ask me, well, could this be a new infection in this patient who's on immunosuppressive agents? This is a patient with lupus. Could this be pulmonary hemorrhage? I can't reliably distinguish that when I'm seeing ground glass opacity on imaging, unfortunately. Couple more examples. Any patient who's on chronic immunosuppressive agents they're at increased risk for developing pneumocystis pneumonia as well as other infections. And also patients with connective tissue disorders are partially immunocompromised to begin with as well. So this was a patient who had ground glass opacities, and I could have put this as the other slide and told you that they were having an acute exacerbation. But in this case, this patient ended up having pneumocystis pneumonia, and there's a little cyst there in their left upper lobe as well. Another thing that's important to remember, not just patients with connective tissue disorders, but other patients who are on with the newer biologic agents, immunotherapies, if these patients have been exposed to TB in the past, these agents can increase the risk of them reactivating their tuberculosis. So if I'm seeing findings on imaging that are a good location for reactivation TB, and especially if they're on a biologic agent, that's something they definitely need to be put on isolation and ruled out for TB. And this one had developed consolidation with cavitation in their right upper lobe from tuberculosis. And then lastly, malignancy. So Sjogren's, patients with Sjogren's syndrome, like I mentioned earlier, are at increased risk in general for lymphoma. And their lymphoma they can get lymphomatous involvement of the septal lymphatics with interlobular septal thickening. We can see lung nodules and masses with lymphoma involving the lungs, as well as lymphadenopathy. And these are big, bulky lymph nodes. Usually, if I'm seeing very large lymph nodes in a patient with connective tissue disorder, these are usually a little too big than what we normally see just from reactive nodes in the setting of a connective tissue disorder. And any patient with fibrotic interstitial lung disease, especially patients, including patients with connective tissue disorders or fibrotic interstitial lung disease from any other cause, they are at increased risk for developing lung cancer. So on a chest CT, their lungs are very busy. They have a lot going on, but it's very important. We're always on the lookout for any new or enlarging lung nodules like this one, this lobulated nodule. That ended up showing up a few years after this, and this was an adenocarcinoma of the lung. And it's more common, just as an aside, most lung cancers, because most of them have to do with cigarette smoking, occur in the upper lobes, because that's where the cigarette smoke tends to go. The patients with fibrotic lung disease more commonly will actually find their lung cancers more in their lower lobes, and sometimes at the fibrotic normal lung interspace. So these were all the different compartments that I went through that we can see involvement in patients with connective tissue disorders. It's not uncommon. We'll see multi-compartmental involvement of the thorax in these patients. Besides involvement of those different compartments, don't forget there are many, many other entities that these patients are at increased risk for, including drug toxicity, acute exacerbation or diffusive alveolar damage, infection, malignancy, and also sometimes these patients may be older or may have coexistent cardiac disease, and they can also be at increased risk for developing pulmonary edema, which sometimes can be difficult to distinguish from some of these other entities as well. So there's a lot to think about in these patients. It's what makes interpreting their scans challenging, but also, fun and interesting, kind of putting together all the different parts of the puzzle in these patients and suggesting that they may have an underlying connective tissue disorder. So don't forget that evaluation of these patients, especially patients with interstitial lung disease, CT is much more sensitive. It's more specific than chest X-ray. So it's very important to evaluate them with CT, especially if you suspect underlying interstitial lung disease. It's important to look for when we're evaluating these cases, or I always look for, especially in a young patient, a young female with interstitial lung disease and NSIP pattern, I'm going to look at their esophagus, and usually I'll put that in my report if their esophagus is dilated or not, see if they have pleural or pericardial effusions, look at their bones and soft tissues. I'm always looking for other clues to try to kind of help me put all the pieces of the puzzle together and sometimes say, you know what, I think this patient has a connective tissue disorder. Or don't forget, sometimes the lung involvement is actually the first manifestation. So as pulmonologists, they may be seeing you before they end up seeing the rheumatologist, because the findings can precede systemic manifestations or positive serology, sometimes by months to years. And your friendly neighborhood chest radiologist sometimes may also be the first to suggest the diagnosis. So that being said, if anybody has any questions, thank you all for your time, and it's a pleasure to speak with you.
That was terrific. Is
Thanks,
it on?
Daniel.
Okay. That was just an incredible whirlwind. And thank you very much for that outstanding lecture. You're right, the neighborhood-friendly radiologist. I also actually want to shout out and say thank you to Drs. Fuss and Bader for joining us as well in support of Amy today. So thank you for coming. This talk is open for questions. Margaret, you had some?
Thanks, Amy. That was really great. And we love coming to you, although you guys probably hate seeing us coming because we always have so many questions. But, you know, we're telling us about all these new signs. And are you guys using AI or some other tools to kind of look at pattern recognition to come up with some of your new signs or?
No, so people could hear that because you had, I guess, the people
Yes.
on Zoom, over Zoom or whatever. So Margaret wanted to know if I use AI for these signs that we can see in connective tissue disorders or for interstitial lung disease. So we, in radiology, we do use AI. So most commonly right now, what it's being used for, as far as it's used in all different parts of radiology, but in chest imaging, we use it for, it helps to detect incidental pulmonary emboli, incidental or suspected pulmonary emboli. It's also, it'll pop up if an endotracheal tube is too low for position, patients with pneumothoraces, patients with rib fractures. I know in the emergency room, intracranial hemorrhage, it has all sorts of applications, but right now, as far as with interstitial lung disease, I know there's research going on and Dr. Ganji's involved with the research, and there are people trying to develop these algorithms, AI algorithms for patients with interstitial lung disease, but not used clinically at this point. And while AI, just so you know, AI, no matter what people say, it will never be taking over our jobs. Okay. While it's good, it definitely misses things and it overcalls things as well. So just so you know that. But it's also a very helpful tool and can help our workflow.
And we are trying to actually bring some software right now to look at that and see if it plays any kind of role. So I'm gonna head to Mark.
Thank you, Amy. It's a privilege to learn from you. I just had a patient, your mention of rheumatoid arthritis and bronchiectasis made me think of a patient I've been following for about a decade who I thought had just straightforward, boring bronchiectasis. And then she got rheumatoid arthritis. And so I'm wondering, now are these related? But it sort of raised a bigger question for me, which is that there's a presumption in your presentation that when a person has a connective tissue disease and has one of these lung manifestations, that the two are related. And I'm wondering, is there a possibility that at least in some of these cases, a person has IPF and a connective tissue disease and somehow they are not related? And is there any way to tease that out?
So that's a great question. Definitely there are cases where they may be true and unrelated. And the most common cause of bronchiectasis is not underlying connective tissue disorder, although patients with connective tissue disorders can definitely get bronchiectasis. Technically, the most common cause is recurrent repeated infections, patients that aspirate, as well as you know, the people in, you know, Dr. Chupin, the pulmonologists who's super specialized in the airways know there's many, many other causes of bronchiectasis as well. So sometimes they're true and unrelated. As far as if we saw, so as far as IPF, you said if there's
Or any of them, like you know, organizing pneumonia, like that happens. There's cryptogenic, obviously, and then 5 years later they may have lupus.
Absolutely. So all of the patterns that I mentioned, so have it's basically a pattern that we're seeing at imaging, and there are multiple causes that can make those patterns. So the whole like purpose of this talk is to just touch on that, connective tissue disorders, can do all these different things in the chest. Not that other entities can cause these patterns. Yeah, absolutely. Absolutely. So when we see organizing pneumonia, probably in the hospital setting, most commonly it's going to be from drug toxicity in patients who don't, the oncology patients or patients with nitrofurantoin or whatever, the patients who have urinary tract infections. So more commonly, we'll probably see it in other settings, but definitely they can be secondary to an underlying connective tissue disorder as well. So. And that's where you guys come in too, to tease it out. And sometimes it can't be teased out. Sometimes, we're left with, there was this pattern and, we really, I know in ILD conference, not everything is straightforward. And, can we say, this is caused by, A is caused by B? Sometimes it's multifactorial or there are multiple other things involved, complicating the picture.
Let's see. All right. So Lloyd says, great talk, Amy. Can you mention IgG4 disease in the lung?
Who said that?
Lloyd Freeman.
Thanks, Lloyd. Okay, IgG4 disease in the lung. So that doesn't have to do with my talk on connective tissue disorders, Dr. Friedman, but basically IgG4 lung disease, it can cause a variety of abnormalities, and usually I don't mention that diagnosis unless that's like one of the miscellaneous diagnoses that I'll throw in sometimes if I have no idea what's causing the interstitial lung disease or the lung abnormality, including amyloid, including Erdheim-Chester disease. So IgG4 related lung disease can definitely have different appearances, including interstitial lung disease. So, but as far as I know, not associated with connective tissue disorders.
And then Mario Perez says, great talk. Any signs to differentiate COVID sequela from connective tissue findings on the CT?
Okay, so that's a great question. First of all, when COVID came along, when we first started seeing cases of COVID, I was looking at usually most of them weren't getting CTs at the time. We were just trying to keep everyone away from the patients and have them isolated during the pandemic. But when they started doing CTs on them, I'm like, this looks just like organizing pneumonia. And I was always curious, obviously those patients didn't end up getting biopsied because they had, the positive COVID test and all the typical symptoms. But I always wondered if some of what we were seeing was actually organizing pneumonia. So as far as with organizing pneumonia, when we see OP can have lots of different appearances as well. That's a whole nother talk, but one of the more common appearances is peripheral predominant airspace disease, which can look identical to COVID. The patients who end up having, it's usually the patients who are in the hospital, who are intubated with severe COVID in the ICU, the ones that end up having residual lung abnormalities, and now we used to use different terms. I used to use the term post-COVID fibrosis, but now there's a newer paper out saying you should just use the term residual COVID lung abnormality. Usually the ones that do have residual abnormalities, it looks very much like NSIP. So they have subpleural sparing, but peripheral kind of reticular markings, a little traction bronchiectasis, a little ground glass associated with it. And the patterns I've seen most commonly look very similar to NSIP. But if you look back at their imaging and in their chart, you'll see, they had severe COVID, in 2001.
Any other questions from the audience? Thank you very much, Amy. That was terrific. Thank you very much.
Thank you.